the things I've taken a few notes, so maybe I'll just address some of the notes here. One of the clear things that's coming through with this panel presentation is that the cause of postpartum depression is very diverse. For Amy, it looks like it was more biological etiology, your hormones, there was something biochemical, these distortions, cognitions, these potential hallucinations. This is bordering on psychosis, and it's a very serious condition, but it's a biological type of etiology, it sounded like. And in contrast, yours was more of a psychosocial etiology. The lack of support, just the isolation, the lack of another mother to talk to for social comparisons, really. And that's why when you went to those moms groups and you met other mothers who were not experiencing challenges with having a baby or having potential postpartum depression, you actually felt worse coming out of there. That's because we need to have support groups that are tailored to individuals who are also experiencing the same type of stressor, or maybe postpartum depression, right? Pair in Latin means to be equal, and pair is peer, and so to be equal is to be a peer, and so you need to have that type of peer support, which is exactly what you were talking about. And this is like exactly what I've studied in the past. I've conducted a large multi-site randomized controlled trial across the province of Ontario. I received over $1 million in funding to conduct this trial, and it was to evaluate the effect of peer or mother-to-mother support for the prevention of postpartum depression. And this was just telephone-based support. So we recruited mothers across the province. We screened over 21,000 moms, and we wanted them to have a little bit of depressive symptomatology in that first couple weeks postpartum. So they had to have an Edinburgh Postnatal Depression Scale score greater than 9. Have most people heard of the Edinburgh Postnatal Depression Scale? So they had to have a score greater than 9 within that first 2 weeks postpartum. We had public health nurses screen mothers, so out in Ottawa, Toronto, Halton, Peel, Windsor, Sudbury, all over, York. Everyone was screening for this trial. If a mom had a score greater than 9, then we tried to recruit her into this trial. And then when we did recruit her, we randomized her to a control group, which was standard care that all moms received, and we randomized them to the intervention group, which was standard care that all postpartum moms received. But we matched her with another mother who lived in her community. So she lived in Oakville. She was matched with another mother who lived in Oakville, who previously felt that she experienced postpartum depression. She came and she participated in a 4-hour training course with me, and during that training course, it was about how to provide support to a new mother over the phone, and she had to have the experiential knowledge of feeling like she experienced postpartum depression. So she had the experiential knowledge. We didn't train her about postpartum depression because she had the knowledge about it, but we trained her about how to develop a relationship over the telephone and how to provide support. And we found that mothers who received this telephone-based support, no other support, they never met face-to-face, but if this mother received the telephone-based support, her chances of developing postpartum depression were cut in half by 50%. And we published this in the British Medical Journal, and frequently I'm contacted by individuals around the world who want to implement this preventative intervention. And if you received this preventative intervention, you probably would not have developed postpartum depression, because we could have matched you with a mother in your community and someone to talk to about your experience, right? So the value of peer support, but we had to do this really large trial to validate this very simple intervention of creating a support network for these new moms, and it was based on experiential knowledge. So I wanted to mention that in relation to yours. In relation to the mind-body connection that you were talking about, we're actually putting in a very large grant to evaluate mindfulness-based cognitive therapy.
Oh, it's great.
By Zindel Siegel. He developed it here at the University of Toronto. And we're trying to prevent depression relapse in pregnant women who have a past history of depression, major depression. So they've had to have had a depressive episode independent of childbirth, or it could have been a previous episode of postpartum depression. And we're going to target these mothers who are pregnant, who are not currently depressed, but we know that depression can be chronic and reoccurring, as Amy has indicated. And so if you've had a depressive episode previously, your chances of developing depression again with the subsequent childbirth is around 25 to 30%. If you have depression in pregnancy, the chances of it continuing into the postpartum period is approximately 50% if left untreated. So we're trying to prevent a depressive episode with this mindfulness-based cognitive therapy. So we're putting in a very large, I'm the PI on it, we're putting that trial into CIHR for funding this September.
Excellent.
And
Excellent.
so we're moving in that direction, so just wanted to say that. Also in relation to what Amy was talking about, she really didn't go seek help for her condition. There's a lot of barriers that she had outlined that a lot of mothers experience, thinking that this is a normal experience, this is common, or feeling that they're afraid that they might be diagnosed with something serious. There might be some stigma associated with this, not knowing where to get help. And so another trial that we're putting in for funding for this September is to have pediatricians screen for postpartum depression within that first year postpartum. So at those well baby visits, you know, when you take your baby in for immunization at 2 months, 4 months, 6 months, and then at again a year, I think that's a perfect time that we should be screening all mothers or all healthcare providers that bring that baby in. We should be screening them for postpartum depression. And then we're going to be evaluating a referral pathway, because pediatricians don't want to screen because they don't know what to do with mothers if they detect them to have some depressive symptoms. So we're incorporating a referral or a care pathway that will refer these mothers to Sunnybrook, to Mount Sinai, and to Women's College. They all have excellent perinatal psychiatry programs. So that's another trial that we're putting in place to have pediatricians be involved, because right now public health nurses are screening for mothers with the Healthy Babies, Healthy Children's program. But that's very early in the postpartum period, and if you're not identified as at risk within that first 24 to 48 hour phone call that you get after the hospital discharge, then you're discharged from the Healthy Babies, Healthy Children program, and then you would have to reactivate yourself to be involved in that program. And if you have any help-seeking barriers like you did, then the chances of you going to that program is very slim. And so we're looking at other healthcare providers that have a relationship with mothers, so mothers are willing to disclose that they might be having a challenging time in the postpartum period. So that's another trial that we're currently conducting right now. Also, we're looking at fathers. I think we've really excluded fathers from this whole picture. I think it's very fair to say that postpartum depression is a family affair. Ed's here, he knows this. That about 10% of fathers will also experience postpartum depression. Mothers typically, this is what the research is saying, there's not a lot of research on this, but we think that mothers experience postpartum depression first, and if she develops postpartum depression, then that places fathers at risk of developing postpartum depression. Maternal depression is a risk factor for paternal depression, as is a past psychiatric history. So if the father had depression before, just like with mothers, that's the strongest risk factor. If you have a depressive episode before, then you're at risk to have another depressive episode with a trigger of a stressor like the birth of a child or death of a parent. So fathers, if the mother is depressed, then that places him at risk for depression, but his depression develops a little bit later. And if you go into the literature, you'll see that Cheryl Beck, some of you may have heard her, she's an excellent postpartum depression researcher from the States. She did a great qualitative study with fathers and postpartum depression and why they develop postpartum depression, the stages. And it's because they discover that the mother has depression, they try to fix it, they can't fix it, and then they feel like there's a loss of their partner, and they start to feel hopeless in the situation because they're also living with a depressed individual, which can be challenging, and then they develop depression. And what's really concerning about this is that now we're seeing children in families where both parents are depressed and probably not parenting as effectively as they could parent. So, and we know that postpartum depression places children at higher risk for poor developmental trajectories. And it's not just because of one single depressive episode. So if a mother has one depressive episode, that really doesn't place a child at risk for poor developmental trajectories. It's the chronic and recurring nature of postpartum depression or of depression that places children at risk.